Sophia Yen, CEO and co-founder of Pandia Health. We are the only women-founded, women-led, the only doctor-founded, doctor-led, asynchronous telemedicine for birth control and peri/menopause. And we also have a pharmacy service that delivers to your door. So I'm going to share my slides, and I know that it's not in presentation mode or whatever, but I'm a little OCD, so I like to know what slide's coming up, and hopefully it won't like jigger too much. If it does, tell me, and then I'll go into presentation mode. But today we're covering peri/menopause 101, what every woman or what every educated person should know. I told you about Pandia Health. We're about women's hormonal health care, precision matched to your biology and lifestyle from your first period until your last breath. And we're not here to replace your primary care physician. We're just here to offer expertise in birth control and peri/menopause, places where most physicians haven't had as much experience or knowledge as our doctors. What makes Pandia Health better than other companies out there is we're asynchronous. So that means that they've shown in research people are more honest about sex when you ask it, not in person, phone, or video, but just a questionnaire like how many partners have you had? Does it hurt when you have sex? Easier to just respond rather than video or phone where you might feel judgment. And then that patients can answer 24/7 at their convenience. So if you're like up at 3 a.m. with hot flashes, that's a great time to start your peri/menopause care. And then because it's asynchronous, we have a HIPAA compliant platform that you can message the physician back and forth until you're both happy. And we realize that gives you unlimited time with the doctor. Whatever you type, I legally have to write, or you could sue me, but hopefully don't type too much. Versus synchronous telemedicine or in-person visits where they're like, I have to see a patient every 15 minutes, next, next, next. And so that is actually, I think, a selling point rather than a negative. Though, as you can tell, I run yappy, and that's part of why we like asynchronous, because if I were to get on a call with you, I'd go on for hours and then I'd let you go on for hours and I never cut you off because that's why I didn't go into family medicine. My visits were 3 hours in family medicine. I was like, I can't do 3 hours per patient. That's just too much. Oh, just a couple more slides on Pandia Health. What makes us different is we are led by an academic physician. So I went to MIT, UCSF. I'm a clinical associate professor at Stanford. I have my master's in public health at Berkeley. But really, I wrote 3,000 birth control prescriptions in 2 years. And I couldn't just sit there and watch women suffer from the side effects. So I took all 40 different birth control pills and ranked them. Most likely make you bleed, least likely make you bleed. Most likely give you munchies, least likely give you munchies. Most likely give you acne, least likely give you acne. And I realized as a person of color that most of us are being taught at these academic institutions, here's the birth control pill your professor likes. If it doesn't work, have a backup and good luck with that. And I'm more scientific based, came up with this algorithm based on age because I'm adolescent medicine and focused on bone health. So you want 30 micrograms of estrogen till 30. Otherwise, you don't have enough calcium, estrogen, and your bones will break. And that'll come relevant later as we talk about the benefits of HRT and osteoporosis. And then race as a proxy for genetics. We were seeing people of Asian and Black and Latina descent have a particular side effect, and then health history, PCOS, acne. And I came up with an algorithm to choose the best birth control pill. And with that, we've used that algorithm on 41,000 patients. We have 93% of our patients happy with the first pill prescribed. We're like at 10 weeks, breakthrough bleeding, acne, headaches, anything like that. You want to switch? And 93% of our patients like, let's go, this is good. And then more importantly, the gold standard at a year, people that are new to the pill patch ring, how many of you still using it? The national standard on research studies, 33%. With our company and the delivery, but mainly picking a pill where you don't have side effects, right? 82%. This is huge. And then for those of you who understand marketing, net promoter score, 81% of our patients would recommend us to their family, friends, etc. And then on the bottom shows you the difference between a doctor who knows how to customize which birth control pill to pick for you versus everybody gets the same that my teacher taught me. 94% reduction in headaches, 71% reduction in nausea, and 57% reduction in breakthrough bleeding. So back to the programming. Today, we're going to cover what is peri/menopause, what are the barriers to care, the hormonal chaos of perimenopause, the symptoms of menopause, all 70 plus of them, and more. And then HRT, what it is, risks and benefits, weight and menopause. I happen to also be an obesity specialist, so I have some basic healthy living tips. And then bone health and exercise tips. I stole these slides, borrowed them from Dr. Tanya Goodridge, who's a local pelvic therapist specialist, PT, doctor of PT. Love her slides and her goal and she's told me also in the UK, they have a campaign called Sticks and Stones, which is to eliminate osteoporosis by I think 2040 or 2045 because it is absolutely preventable. And so we'll tell you how to do that. And then lastly, just a page of resources of books and podcasts, etc., that we like. So the current state of menopause care. See that little dot in that giant circle? There's about 4,100 Menopause Society certified practitioners in all of North America. There are 75 million women in the United States that are entering menopause. That's 1 million a year. Perimenopause, that's 2 million a year. And then post-menopause, because most people that are Menopause Society certified practitioners are like, you're going to find this patch on my dead body. Because the way I think of it biologically is at age 52, your ovaries are like, thank you for your service, out to pasture. You have given birth, you have hung around and grandmothered. Everything above 52 is gravy. Everything above 52, we need to biohack. And so, if we give you estrogen for 10 years, and the old school doctors will be like, we'll give it to you for 10 years and then we take it away. If you take it away at 10 years, what's going to happen in 10 years? The same thing that happened when you took it away 10 years ago. So unless we all of a sudden manifest estrogen out of some random body part, you want to live with that brain. You want to live with that vaginal flora, that vaginal health, that prevention of osteoporosis, prevention of heart attack until you die, right? So that's the logic there. But your provider or physician does not have to be Menopause Society certified. It just means if they have, that they're up to date on the latest papers, science, evidence-based research, as opposed to just, waving their hands or MAGA influencers out there or MAHA influencers out there. But certainly if they kept up on the papers, that's fine. And so maybe right now I give you the two questions that you ask your doctor to check if they're up to date on the latest and greatest. So number one is, does estrogen increase my risk of breast cancer over not taking estrogen? And if they say yes, then they lose, and you need to refer them to the book Estrogen Matters by Dr. Blooming, who is a oncologist, and he goes over the flaws, and I'll go over it later in the Women's Health Initiative, that estrogen and HRT does not increase your risk of breast cancer more than baseline. So 1 in 8 people without HRT will get breast cancer, and 1 in 8 people on HRT will get breast cancer. No increase from the HRT. That's question number one, to test your provider. Question number two, how long can I stay on HRT? And if they're like 10 years, wrong answer. Or like, this one's a third bonus question, is what is the latest state of care for menopause? And if they're like lowest amount of hormone for the shortest amount of time, that was 20 years ago. Okay. So no longer and. Those are how you check if your provider knows their stuff. Menopause is underdiagnosed, undertreated. There are 0 hours of menopause training required for OB-GYN, internal medicine, family practice. They surveyed OB-GYN residencies today, and I believe 21% of those that responded, or was it 31? Anyway, 31%, let's say. 31% that responded had some menopause curriculum. That could be an hour, that could be a clinic, that could be a week, that could be a month, but flip that. 69% of OB-GYN residencies today, not 30 years ago, have no menopause curriculum. So then I asked some med students, hey, Menopause is hot right now. Did they stick in an hour, somewhere in med school, 4 years of med school? Did they stick in 1 hour on menopause for something that will 100% affect every one of us that were born with a uterus? And 70% of us will have symptoms that we could treat with medications. Did they add anything? No, they did not. At one of the top medical schools in the world, they have not added any menopause curriculum. They said if you ask on family medicine, maybe you'll get something. But again, as we mentioned here, family medicine is not required to have anything. Neither is OB/GYN. Neither is any of these residencies. Some of them do, and that's great. And some of them are amazing, but a lot of them have nothing. 90% of menopause symptoms go undiagnosed. Part of it, I get it as a doctor. There's like so many things that it could be, and it's all kind of vague, but it's gotta be the right age. Their period's got to be going this way. And then it comes together on average. It takes like 7 visits before someone is diagnosed with menopause. And if it takes 6 months to get into a doctor's visit, what is that? 7 times 6, 42 months before you're going to get diagnosed, right? And only if you have the luxury of going into the doctor's office. What if I got 2 jobs, kids, and parents to take care of? When am I ever going to get in to see a doctor? Only a third of people who show up for menopause care actually get treatment. A lot of people get the old school, and it happened to me, hand on shoulder. Just old age. You need to go exercise. You need to, be healthier. And my doctor pulled that on me. And that was before I became a Menopause Society certified practitioner. I was like, oh, okay, yeah, I guess it's just old age. But like she didn't realize I'm an obesity expert and people wait 6 months to see me. I tell people what to do to diet and exercise. I changed nothing from last year to this year, and my waist disappeared and my cholesterol shot up. So no, it's not just old age and it's not just diet and exercise. So I feel your pain, is what I'm saying. Like I mentioned, 1 million women are going into menopause each year in the United States. 60% of fractures could be avoided if we all went on HRT. There's a 50% increased risk of heart disease if you can't go on HRT, 24% increased risk of colon cancer, 21% increased risk of diabetes. And again, just because I love biology, when you take away the estrogen, the arteries no longer dilate. So that's not good. Then it fills up with bad cholesterol, LDL. And then the triglycerides are also bad cholesterol, and that goes up, and that indicates that you're heading towards insulin resistance, which is this risk of diabetes, which is this risk of heart disease. And as an obesity and physician, I'm like, if that's what happens when you take away, then you put it right back because I don't want any of that. I don't want that. So the definitions is really important. And part of this, I'm going to emphasize the numbers because there are some people out there just trying to freak everyone out that you all have perimenopause, you all need to get tested and all this stuff when you don't need to. So don't let people be all freaking out until they're getting closer to these ages. FMP is your final menstrual period. We've all been in the doctor's office. When was your LMP, your last menstrual period? But with respect to perimenopause, it's all about that last period. And for those of you who haven't gone through it yet or who are getting there, you're in this limbo because we define menopause as 12 months without a period. So you get a period and then you're like, yeah. And then like 6 months later, you get another one. You're like, boo, I gotta restart the clock. And then you do it again and you're like, yeah. And then you get a period and you're like, boo, I have to restart the clock. So I'm a control freak. I don't like limbo. And I'll tell you my hack for getting around that later. The median age of the final menstrual period is 52 and a half. So if you are doing it way earlier, then that's called like early menopause and or premature ovarian insufficiency. And it is rare, but it certainly can happen. But I'm going to focus on what's common and not what's rare. Rare means 1 out of 1,000, 1 out of 10,000, 1 out of 100,000. But we will spend greater than 40% of our lives in postmenopause. And so don't we want to live that optimally rather, and you won't get a gold medal for seeing how long you can white knuckle it until you give in to treatment. You will get no prize. You will only suffer. So I'm a doctor. I believe in drugs and science. Please let us help you. Don't suffer. Greater than 60% of us are going to survive until 80. I want to live to 100, 120, but in good health. And then perimenopause by definition. I know people like, and then it already began. Blah, blah. No, if you don't have irregular periods or fewer periods, if your periods were every 30 days and now they're 28 days, if they haven't changed one way or the other, then it is not perimenopause because that's the definition. Your periods got to get different, okay? And then all these other symptoms happen. And then post-menopause, we all say menopause, but I think what we mean is post-menopause because menopause is just a day. It's the 1 year anniversary of your last period, and post-menopause is any time after that last period. So just to do it in a graphical manner, the average age of final menstrual period, sorry, is 50.3 in this slide, and the average age 1 year after that would be 51.3. And then perimenopause is average age 47.3. So for people who are trying to freak people out that, oh, you just had a baby at 40 and now you're in perimenopause, unlikely, possible, but unlikely because all of this is plus or minus 5. So you could go down to 42 and be in perimenopause, but it would be unusual. Don't freak people out at 35. Don't freak people out at 40. Like if the average age is 47, that's still 7 years. That's enough to grow a second grader. You know what I mean? Don't be freaking out, people, for 7 years. But certainly if you have any of these symptoms, then yes, yes, definitely go run, get some care. So perimenopause is also broken down into two phases. There's early perimenopause, which is irregular menses and all sorts of weird things are going on. And I think that part is best treated by taking over the chaos and keeping smooth hormones. Late perimenopause is the period of waiting for no more periods. And so it could be months between, another one happening. And that part is possibly better treated with HRT. And then once the hormones are gone, then definitely HRT versus birth control. So I just want to illustrate this is kind of the 4 seasons of a hormonal change. It's like nothing happening, but then puberty happens, and then you got your hormones going. Then chaos of perimenopause, and then nothing down here. The estrogen and progesterone down in menopause. And in chaos, you don't want to add extra estrogen on top of these estrogen highs because then you're going to have headaches, you're going to have irregular bleeding, you're going to have weirdness. But once it's all gone to zero, yes, add back so that you were back where you were before this chaos happened. So just differences in perimenopause duration. The menopause transition can be 2 to 14 years, but the average is 4 to 7 years. And it's longer for Black women than white. And there's if you have earlier onset, then it lasts longer. So that sucks. So the earlier you get menopause, the more likely it's going to be longer and possibly up to 4 years longer. Racial differences, they've shown that the African American women are 8.5 months earlier. The one study, when they adjusted for health status, weight, cigarette, alcohol, educational attainment, employment, past birth control, physical activity, then that gap was eliminated. So if we can decrease disparities, then we could have similar menopause onset, perhaps. Hispanic and Native American women, again, earlier, but again, health status, educational attainment, employment, physical activity, etc. If we controlled, maybe that would be different. South Asians, same thing. They are earlier. East Asians are more, quote, standard, and Japanese Americans are even later menopause. Risk factors for early menopause. What's key is family history of early or premature menopause gives you a 6 to 8 times greater risk of earlier premature menopause. And so I think when we look at the attribution, family history accounts for 50% of when you're going to get menopause. So ask your mom for sure, and maybe your aunties on your dad's side if applicable, and that will give you a better idea of when you might get peri/menopause. If you've never given birth, then you have a 2 times greater risk of premature menopause, 1.3 times risk of early menopause. And then early menopause is 40 to 45. Premature menopause is less than 40 years old. If you got your periods early, then 1.8 times chance of having your menopause before 40. and 1.32 between 40 and 41. And if your menstrual cycles are every 26 days, you're running through eggs faster than 1.4 years earlier. If it's greater than 25 days, then it's 1.7 times risk of early menopause. Hmm. So that's an interesting thing. Confusing. So different studies have different results. Risk factors for early menopause in terms of lifestyle, surgery, etc. Smoking will increase the onset of menopause. If you're underweight, it'll increase menopause and history of heart disease. If you had one of your ovaries taken out 1.8 years early, if you kept your ovaries but you took out your uterus 1.9 years earlier, and lower educational attainment, early age at when you gave birth to your first child, separate, widowed, divorced, I consider that stress, or unemployed. These are risks for early menopause because your body's probably like, you're like stressed out of your mind. This is not a time to have another baby. Risk factors for late menopause: overweight, obese have 50% higher risk of late menopause. If you've had a ton of children, late menopause. If you have PCOS where you weren't able to pop out your eggs, and I guess the eggs are kind of there, and so you can have a late menopause there. If you have greater than one drink per week, you have menopause later by 0.6. And if less than or equal to 3 drinks per week, then 0.75 years later. And red and white wine showed the strongest association. I guess if you like beer, go for it because there's no association there. And if you have fresh legumes, then 0.9 years later per portion per day. The symptoms of peri/menopause, because I think we stick it all together and it all kind of comes together, but by definition, your menstrual cycle has to be affected in some way for perimenopause. And then vasomotor symptoms are hot flashes and night sweats. Vulvovaginal symptoms or genital urinary symptoms are painful sex. I call it sandpaper vagina, ripping, and I don't think I included the slide, but I might, of how it affects your vagina specifically. You have rugae, which allows it to stretch, and then you no longer have rugae. And the skin thins, and so rather than you can like have some abrasion and friction, it rips and can have micro tears and bleeding, but definitely pain. Sleep disturbances. Who hasn't had the 3 a.m. wake up? They can't go back. This seems to be a definite part of peri/menopause. And then depression, anxiety, moodiness. People have been put on SSRIs, antidepressants, and when they went on HRT, estrogen, progesterone, got sleep, got relief, maybe also just calmed their nervous system, they were able to come off the antidepressants. So don't let someone blow you off and be like, it's just anxiety. It's quote hysteria, thing that people with uterus have. And then other symptoms that are associated: cognitive concerns, the brain fog, if you all haven't had it, is real and it's worse than postpartum breastfeeding brain fog. It's maybe because we're all at the top of our game. And so if I can't come up with a word and I'm given a talk, that looks really bad, or if I'm in front of my team and I'm the CEO and I don't remember this or don't remember that, that looks bad. And so there's definitely the brain fog, and it's stressful and it makes you look bad. And 1 in 5 women, when they hit menopause, consider leaving because it's so bad, the brain fog, but also other things that are going on and it's like not worth it or whatever. Joint pain, dry eyes. My husband says everything is dry. So your hair is dry, your skin is dry, your eyes are dry, your ears are dry and itchy, and your vagina is dry, everything is dry. And then change in weight distribution. There is no one universal menopause syndrome. Each woman can have her pick of all the symptoms. And these are just a sample of all the symptoms you could have: anxiety, mood changes, feelings of loss of self, hair loss or thinning, increased headaches or migraines, hot flashes in 75 to 85%, increase in facial hair, that one random hair that you saw on your mother that you thought you'd never get, but you got one too. And then palpitations, problems with brain fog, the urinary tract infections, feeling needing to pee when there's no pee to be had, reduced sex drive, ringing in the ears, and vaginal dryness and pain. As I mentioned, it affects every cell in your body from the top of your head to your toes. And therefore, I think 1 hour in medical school wouldn't hurt because the eye doctor needs to know. The bone doctor, joint doctor needs to know. The radiologist needs to know. All the doctors need to know this can happen and how will it affect their part of the body that they're interested in if they're focused only on one particular part of the body. One thing I wanted to bring up was heavy menstrual bleeding. It's very popular in the lay press, and in fact, I think I got on the Kardashian blog because of it. But the example I want to give is I had two friends, and this is before I went into menopause, because if I had been in menopause, I'd be like, girlfriend, let me take care of you. But this was before I went into menopause. And one of them said when she hit menopause, perimenopause, she had random heavy bleeding for an entire month that she could not visit her friends because she was afraid if she sat down on their sofa or their chair, she would get up and leave a mark. So that is like horrifying. If you are bleeding that much or bleeding more than 7 days, please see a doctor. We have drugs. We can turn that off. That blood loss can result in the need for transfusion. That blood loss can result in symptoms of your heart beating faster because you don't have enough blood, so your heart has to pump it around, or being cold or being tired. These are all symptoms of iron deficiency because you lost this blood. Okay. And then I had another friend who was, having weird periods or had nothing and then went to Africa on a business trip, had no menstrual products, and is bleeding like stink in a foreign country with no access to doctors that, are comfortable dealing with women because there's very sexist, doctors out there in the world and in our world and in the United States too. So like don't put yourself in that situation. Let's prevent that. Heavy blood flow for 3+ days. Long blood flow is 8+ days, and it happens in like 25% of us. And 5% will have 3+ episodes of this situation. So I guess my friends fell into the 3+ over here in the heavy bleed. Tired. We asked people that are perimenopause, menopause, you all tired? 27%. That's like a third. 24% worn out. Other reasons for fatigue I mentioned, if you're having iron loss, 33% of 19 to 49-year-olds have iron deficiency. So usually as doctors, we only check and care about anemia. But if you have enough iron deficiency and it gets bad enough, then it will hit anemia. So if you're feeling tired, make sure they check for iron deficiency in addition to anemia, because if you treat the iron deficiency, you won't feel as tired. Your heart won't have to work as fast. Your body will be warmer if right now you're in the East Coast and you're freezing. But if you're in the West Coast, we're very warm right now. Palpitations, I didn't realize 46% of menopausal women, that's almost 1 in 2, will have fast racing pounding heartbeat. And usually it's benign, meaning no big deal. But if you have like chest pain or radiating left arm pain or to your jaw pain, that could be a headache. So not a headache, heart attack, run to the ER and get treated. But we could save a lot of ER visits and cardiac workups if we treated with HRT than avoiding these palpitations in women. Triggers are stress, caffeine, dehydration, alcohol. I'm looking around as I speak for water. Support your heart. Make sure you hydrate. Decrease the stress, but I get it. We have stressful lives, but just taking 5 minutes to take a deep breath in your mouth and then exhale out your nose. I don't know if you've all learned this square block breathing. You like breathe in for 4, out for 4, in your nose 4, out your mouth 5, or vice versa. Just doing that, or listening to spa music, as I call it, for one song. If you do that once a day, they've shown it improves your heart rate and stress levels in your body. And then menopause hormone therapy may reduce palpitations and calm down cardiovascular irritability. So again, to re-emphasize that before menopause, your hormones were like this. In perimenopause, it's chaos. And with the high estrogen, you get tender breasts, weight gain. With the progesterone drop, you get irregular bleeding, you get sleep changes. With the estrogen drop, you get hot flashes and mood swings. And so if you can prevent these drops by having stable, if you can prevent the spikes, then you avoid that. And with the extra estrogen, you have increased fodder for this heavy bleeding situation. And then if you want to get really geeky technical, this is what happens. As they say, the ovaries go out not with a whimper or a bang, but like kicking and fighting and screaming. And so it can like pop one egg and then bunch of months, no pop egg, but then two of them stack up. And then when they stack up, this is when you get the estrogen on top of estrogen. And then if you're already on a constant dose of added estrogen, then you're going to have bad side effects. And so that's what happens with HRT. When you do a birth control pill, it's so high that it just shuts off your ovaries. So your ovaries don't do this random popping and stacking and stuff like that. It's just calm. And then once you know that you've hit menopause, and then you can switch to HRT. So again, the high estrogen causes breast tenderness, worsening migraines, growing of fibroids, risk of endometrial hyperplasia, and cancer. And so the treatment is, instead of this chaos, this is your levels on birth control. And birth control can be thought of as HRT because it's estrogen and progesterone. It's also used for birth control because you can get pregnant until 1 year after that last period to make sure you're out of that window. The second greatest spike of unplanned pregnancies is 40 years old because they're like, I don't have sex that often. I'm probably in perimenopause, not going to happen. So just know you are pregnable until 1 year after that last period. And there are many oopsie babies. You've seen them. And so unless you're willing to deal with that, please take precautions. So the birth control not only helps you with that, but it also calms things down. And the vaginal ring is the new player in this market, and that we've usually blown it off. It's too expensive. But once you hit our age, we could probably afford the ring. There's a 1 month ring. You just change it once a month. The Anovera, you change it once a year. And you can take it out for 3 hours during sexual relations, but if you don't remember to put it back in, then you risk getting pregnant. Only 1 in 10 people with a penis notice it, and only 1 in 10 of them will ask you to remove it. So only 1% will care. 99% will not care that it's there. And then there's Slind, which is a new progesterone only pill, not the over the counter one. But if you're worried about blood clots or you can't take estrogen for one reason or the other, then you could use this, and this will block the eggs from popping. And you could add estrogen patch because this will flatten it out, and then you can add stuff on top. But this is why the IUD doesn't work, because the IUD only blocks the eggs from popping out about 30% of the time. 70% of the time it doesn't. And so if you're part of that 70%, then you're going to feel this hot flashes, night sweats because the estrogen is fluctuating because it's popping eggs. It's preventing unplanned pregnancy, but with a progesterone only method, except for this Slind pill, which is known to block the eggs from popping out, then you don't get this flattening, calming effect. And then I have a talk on making periods optional, which is basically just taking your birth control pills continuously and skipping the sugar pills if you want. This works for, a 14-year-old all the way through perimenopause. So estrogen, we talked about, affects every part of your body. The drop in estrogen level causes hot flashes. The fluctuation can cause migraines and all sorts of other stuff. And I like alliteration, so it's key for your blood, bone, and bladder, and then your joints and your heart as well. This is where I go over it. So the vulva is the outside tissue of your vagina, and it thins that skin. So you can see here, this is well estrogenized, all these layers of cells on top, and they're rugated so it can stretch more, whereas low estrogen, it's thin and it has no room to stretch. It is what it is. There's narrowing of the vaginal canal and there's poor distension. There's decrease in lactobacilli, which are the good bacteria in your vagina. And therefore, if you decrease the bacteria, you can theoretically increase yeast infections because normally it's a balance between the bacteria and the yeast. But if you kill the yeast, if you kill the bacteria, then the yeast can take over. A higher vaginal pH, which increases kind of inflammation in the area, decreased secretions, sometimes increase in pathological vaginal discharge. And as the vagina dries up, the urethra is right next to it. And so it too can dry up. And when that's dry, it can increase your risk of urinary tract infections. The example I give is I had a family member, age 70, started getting recurrent urinary tract infections. And as adolescent medicine, when that happens, we're like, oh, you're having lots of sex. I was like, hey? And she's like, no, no. And I was like, oh, okay. And then I learned about this, and she got a urinary tract infection. She got urosepsis, which is when it's so bad it goes into your blood. And she was in the hospital. And now we're hearing about a whole bunch of older people getting urosepsis. And it's because increased urinary tract infection, urosepsis. And so then throw down some vaginal estrogen to plump that all up and then decrease your risk of urinary tract infection, decrease your risk of urosepsis. I also helped out my friend whose mom was in an older folks home and was having recurrent urinary tract infections. Like, ask her doctor, throw down some vaginal estrogen. Threw down some vaginal estrogen, saw him a couple months later. He's like, thank you. She has no more urinary tract infections. And I was like, and I just saved this whole old folks home from urinary tract infection because hopefully that doctor learned and applied it to all of the patients that were 60 and above. So if you talk to any urogynecologist, this isn't a gynecologist, this isn't a urologist, this is somebody who specialized specifically in women's urology. They recommend anybody 52 and above just throw down some vaginal estrogen. If you use systemic estrogen, it will cover the vagina 50% of the time, but 50% of the time it won't. So if you notice any dryness down there, then start throwing down some vaginal estrogen as you get older to prevent the recurrent urinary tract infections, etc. The treatment of genital urinary syndrome of menopause is local. Don't need systemic treatment for it. You can have a cream, you can have a tablet, and then there's a ring, which is a 3-month ring that you can use. And just know that there's 2 different rings. There's a 3-month ring that's just local, and that's called E-string. And then there's also a 3-month ring that's systemic, the whole body, and that's called FemString. Both of those are very expensive, but if you can afford it or you can get your insurance to cover it or whatever, then that's an option. There's also a selective estrogen receptor modulator, which is Osphena, which is another option. But all of these will restore your vaginal blood flow, decrease the pH to a normal acidic part, improves the thickness and elasticity of the tissues, and you'll get better within a few weeks, probably 2 weeks, and then full efficacy in 2 to 3 months. There is no increased risk of endometrial, breast cancer, or heart attacks with the local estrogen. Systemic estrogen is a different thing, but local estrogen is totally fine, even with somebody with a history of breast cancer. So now we come to weight gain and menopause. So I was told by my doctor weight gain is mainly related to aging and lifestyle, not hormones and hormone therapy. However, when you take away the estrogen, the fat deposits in different places. And so if you know me, 99% of my wardrobe is skirts. And I've accumulated amazing skirt, wardrobe over these years. And all of a sudden my waist didn't fit. And I was like, oh, am I gonna have to do metformin or we're gonna have to do GLP-1? Because I'm not throwing away all these skirts that I've accumulated over the years. And then I learned about menopause and I had been on constant birth control pills, so I didn't know when my last period was, but my waist disappeared, my cholesterol shot up. So I switched from birth control to bioidentical estrogen, FDA approved, not compounded, not pellets or anything like that. And my waist came back. And I was like, oh, thank goodness. Because when you take away the estrogen, the fat deposits centrally. It's just a phenomenon that we know about. And from an obesity physician point of view, it also deposits viscerally. So that means in your liver. I call that foie gras of a human being. And then around your heart and in your arteries, which we talked about earlier. And I was like, if that's what happens when you take away estrogen, put it back, because I don't want my arteries clogging. I don't want my liver being filled with fat. And I definitely like my waist. So that is a benefit of the estrogen. And then we talked about insulin resistance. Insulin resistance makes it harder to lose weight if you're trying to lose weight. It just wants to, when you have high insulin, it just stores a whole bunch of calories and turns it into fat. So you don't want that. And menopause is associated with decreased lean body mass. So again, if that's what happens without estrogen, put the estrogen back. Or now there's some discussion of potentially testosterone as well, but the focus is no longer cardio, but more building muscle to pull on your bones to maintain your muscles. And that's the new take, is build muscle, not cardio, the little cardio just for health. My healthy eating tip, time restricted eating. Doesn't have to be anything crazy. Just don't eat from after dinner until breakfast. And my husband and I were like, who eats after dinner? Is everyone having like a midnight snack or something like that that we don't know about? But eat your dinner at 6 p.m. and you have breakfast at 6. That's a 12-hour fast you just pulled off. And the research has shown that's good enough. Okay, you don't have to do anything crazy. You don't have to do an 8-hour window or whatever, just from breakfast until dinner. I have had patients in my obesity clinic and they'll have cereal as a snack after dinner. And I was like, that's the worst possible thing you could do, to have 100% carb snack right before dinner. No. So all snacks should be fruit or protein, or start with protein and then add carbs. So the plate model's at the bottom, and I like to think of it flipped a little. So at the bottom is fruits and vegetables. Every meal you have, breakfast, lunch, dinner, or snack, half should be fruits and vegetables. And then the new phrase is protein first. So you start with a minimum of whatever you're eating has to be a quarter protein. And only as much protein can you have carb. And so for breakfast, most of us suck, right? Cereal, bagel, no. Only as much nuts or eggs or or peanut butter or whatever can you have your bagel? Can you have your cereal? And so for me, I'm always throwing eggs and turkey and nuts to like stack it up so I can equal the amount of carb that I want to eat. But start with protein, and only as much protein can you eat carb. And as a Chinese, Taiwanese person, that's like, because we're like, bowl of rice, everything else on top. No, you start with the salmon, chicken, broccoli, and beef, and only as much that do you get rice or tortillas. Or like, you can't have tortillas and rice, or you have to have half a portion tortilla, half a portion rice, less, equal it with protein, and particularly pasta. Pasta is no longer a main dish. Pasta is a side dish. Or if you do pasta, you got to double it with vegetables and equal it with protein. So it's just a new way to look at portions. It's huge, and it makes a huge difference. Eat 3 times a day, possibly small meals every 3 hours, and definitely do not sleep within 2 hours of eating. So I tell my patients, if you take a nap, if you get a midnight snack, you're staying up till 2. Because if you go to bed before then, it will turn it all into fat. And once a fat cell is created, it never goes away. If you lose weight, it'll shrink, but it'll always be there metabolically saying, feed me, feed me. I want more calories. I want more calories. No, do not create a fat cell. Do not sleep within 2 hours of eating. If you Google Brian Lian YouTube Sway, he created these videos for our obesity clinic, but everything he says there can be used by anyone. And he goes over the plate model, he goes over mindful eating, he goes over reading a label, and some other tips as well. And then 60-60-60 I think works for everybody. But if you're going to do a GLP-1 or bariatric surgery, then you definitely should do 60-60-60. But this is something for all of us to do or strive for. And I have to credit Dr. Pratt, who we at Stanford stole from Harvard. It's 60 grams of protein, 60 ounces of water, and 60 minutes of physical activity a day. And the 60 minutes doesn't have to be together. It could be 10 minutes out of every hour and you're hanging out 6 hours, and you got that done. Or it could be 20 minutes, 3 times a day. Or if you want to be a stickler, I'm like, if you haven't done it by the end of the day, you don't go to bed. You do the 60 minutes and then you go to bed. Bed is also important. And they've shown that if you are lacking an hour of sleep and you can get another hour of sleep, you can lose weight. And I was like, what a better way to lose weight than just to sleep. Right? Like, I'm totally into that. That's the best way to lose weight. I will sleep for you anywhere, anytime. You can take an afternoon nap, but don't take it more than an hour because it will mess up your sleep cycle and stuff like that. So back to estrogen. Most prescription HRT is bioidentical, so body identical, same as the molecular structure running through your body. And some people say synthetic, not synthetic. All of this is synthesized. It may have come from a yam, but like they had to make it. They couldn't just suck out some estrogen from a yam, okay? So most of this is synthesized. The only one that's not synthesized, I think, is conjugated equine estrogen, which they took pregnant horses, it was mare, that's why it's called Premarin, pregnant mare urine, and just took the estrogen from there that maybe not synthesized, but definitely extracted, So, but anyway, if you want to talk bioidentical, almost all prescription HRT is bioidentical. It's just a marketing term. And it comes in patch, spray, gel. It also has oral versions as well as vaginal versions. And what they use in the Women's Health Initiative, this was a study that came out with the results in 2002 and took away estrogen from 2 decades of women, aka my mother's generation. And what it was is this was like 25 of the best and the brightest researchers in the nation. So whatever they said, the rest was like, oh, they know their stuff, so I just trust them. And there was 5 of them or so in that group who were like, too many women are getting estrogen. Pharma is just shoving it down people's throat. Pharma is evil, and I do believe sometimes pharma is evil. But as soon as they got a whiff of something, they're like, we're going to have a press conference. We're going to shut this all down. And the other people like, once you let that cat out of the bag, you can never put it back. And never in the history of science and academia had anyone had a press conference before you ran it through the New England Journal or Lancet or some trusted peer review to look at the data to make sure it was good before you had a press conference. But they had a press conference and they said, when you do HRT, there's increased breast cancer. But they didn't realize that the increased breast cancer was only 8 out of 10,000. So 9,992 people would benefit and 8 out of 10,000 would get breast cancer. And instead, they just scared everyone about it. And somehow the conclusion was that estrogen leads to breast cancer. However, when they did further analysis of this, there was one group that just had estrogen and no progesterone, because estrogen stimulates the lining of the uterus. And so we give progesterone to block that. But if you don't have a uterus, then you don't need the progesterone. So the people who had their uterus taken out, they just got estrogen. And the group that only got the conjugated equine estrogen, they had a decreased risk of breast cancer by 22% and a decreased death from breast cancer by 44%. So estrogen, conjugated equine estrogen, specifically decreased breast cancer and death from breast cancer if you were to get it. So now we think it's the synthetic progesterone that was in this study that caused it, and that's medroxyprogesterone acetate, which we generally do not use anymore for HRT. And so the problem with the WHI study was that it was actually decreased breast cancer and decreased death from breast cancer from the estrogen, that they used stuff that we no longer use today. And then lastly, the average age of the person in the study was 63. And we now know that you should start your HRT within 10 years, and the average age of menopause is 52. The average age of the woman in this study was 63. So it was just like a bunch of issues with that study. But with that study, 2 decades of women were deprived, and a whole bunch of doctors still think that estrogen results in cancer, breast cancer specifically. So I just wanted to show you that, you can take a pill every day. There's a gel or a spray that you can put on your arm. If you've never seen a patch, this is what a patch looks like. It's pretty cool. This is the twice weekly patch. If you've seen the once a week patch, once you've tried the twice a week, you can't do the once a week because it's bigger and fatter, but you totally can. It brings you joy. It's just bigger and fat and thicker. As I mentioned, there's a ring that's systemic, and that's fem ring, and then there's a ring that is local. They both go in the same place, but it's just how much estrogen is coming out and does the estrogen go everywhere. And then local, you can have a cream twice a week, or you can have a tablet twice a week or every day. I have to look into that one. As I mentioned, we add the progesterone to protect the uterus. So a lot of doctors will be like, you don't have a uterus, I'm not giving you progesterone. But we've also found that progesterone helps with sleep. And it also kind of calms the mind. And there's no negative to the progesterone because we are not giving that medroxyprogesterone acetate. We are now doing micronized bioidentical progesterone, which is called Prometrium. It's FDA tested, FDA approved, don't have to be compound, don't have to be any of that. But so you can ask for it for that. And there are no studies showing increased breast cancer with this bioidentical progesterone for up to 5 years use. And then this is just the stat that I talked about before. So to summarize, HRT's reputation suffered due to a flawed study of the Women's Health Initiative, which was 2002. And the current view is HRT is the gold standard. It beats anything out there. People are like, oh, they're non-hormonal options. Yes, but it doesn't work as well. HRT works like 70, 80%. The non-hormonal works like 30. And the quote, just eat yams and things with estrogen in them, well, like 5%. But also know that placebo works 30%. So if you add placebo plus the reality of 5, you get 35% will work with yams. Key is to see a menopause specialist or ask them those 2 questions that I asked you just to check, or a Menopause Society certified provider. The benefits and risks, it works. It prevents the symptoms. It prevents osteoporosis, heart disease, and potentially dementia. It depends on your personal history of breast cancer. If you have breast cancer that's estrogen sensitive, then no, we cannot give you systemic estrogen. But like I mentioned, that one, estrogen decreased breast cancer. And there's actually this new thing called selective estrogen receptor modulator, you heard, but a specific one called basidoxifene. So DuaV has estrogen, a good one that decreases breast cancer, plus basidoxifene, which is anti-estrogen at the breast and pro-estrogen in the vagina and possibly the rest of the body. So for breast cancer survivors, that's a potential option. Modern methods, as I mentioned, are transdermal through the skin because they have a decreased risk of blood clots. If you take it by mouth, then it goes through your liver and that activates blood clots more than something that just goes through your skin, such as a patch, the cream, or the gel. And then within 10 years of menopause, because, I also didn't explain, like, if your arteries are hard and they start filling up with cholesterol and you let that do for 10 years and then you throw on something that causes blood clots, you're going to get heart attack, stroke. So you don't that's why you got to get it in within 10 years. But if you are a person who missed the boat because they had all this horrible data back there, it is shared decision making. So if it's been 10 years since your last period, but your cholesterol's fine, you don't have high blood pressure, you have a CT cardiac scan, which looks for cholesterol in your heart, and it's normal, then, it could be a risk-benefit discussion with a doctor or provider who's willing to take that risk. Unfortunately, my company being an asynchronous telemedicine company, we cannot take that risk. So you have to see a doctor in person who's willing to take that risk with you. So the FDA-approved reasons for HRT, MHT, HT that Pandia Health can prescribe, unfortunately, are limited to this. It's genital urinary syndrome of menopause, and that will only get you the local estrogen. So need to pee, but not a lot of pee there, or recurrent urinary tract infections, vaginal dryness, painful sex, moderate to severe hot flashes or night sweats. And then my last one, I like to say, as a minority, we never get a leg up in medicine. But as a minority, 75% of us are lactose intolerant. And so we suck at getting calcium and vitamin D. And so we are instantly at risk for osteoporosis. Or if you're a small framed Caucasian woman or just a small framed person or have a mom that has a history of osteoporosis, you are at risk for osteoporosis. Then you qualify for systemic estrogen. And so this is what we can prescribe for. And if you treat for this, you may have the side benefits of all this other stuff, but we cannot prescribe for this other stuff. We can only prescribe for this. And any doctor that prescribes outside of that, you're asking them to take a risk. Osteoporosis and menopause, 1 out of 2 women will get an osteoporotic fracture, 1 out of 5 men. And as I mentioned, it's totally preventable. Osteoporosis is decreased bone density. So on the left here, you see there's not much space. You need some space. On the right, you see lots of space. And so that can break. Increase in bone fragility, leading to higher risk of fractures. The decreased risk in estrogen leads to a higher risk of osteoporosis. Until age 30, you're building your bones, and then after that, it's just downhill. And so you need to build up your bone bank, and then you take from that bone bank. And then when you start losing this estrogen in perimenopause, then there's accelerated bone mass. Women lose up to 10% of their bone mass in the 5 years after menopause and also in the years leading up to it. Estrogen is essential for bone health. It regulates the balance between breakdown and formation. There's the class and the blast. These are things you learn in med school. As estrogen falls, the bone loss accelerates, and then the years following are the most significant bone loss. And if you add HRT, then that can block that peri/menopausal bone loss. Alternative approaches is emphasizing lifestyle changes, and you absolutely need the lifestyle changes. Other symptoms of osteoporosis, any fracture above 50, you should consider that you have osteoporosis by definition. It doesn't even have to get a DEXA. It's just like you got a fracture, a major fracture that you weren't like in a car accident or something. That is osteoporosis. Height loss. My mom she and I used to be exact same size. I could wear all her stuff and share all her things. 5'3", and we just took a picture. She's 80 now, and I'm 53 or something like that, and 3 inches she's lost from spinal compression and maybe some bowing, but really just spinal compression. I knew that she'd had some like spinal fracture or whatever, stuff like that, but like 3 inches we noticed on the latest photo that we took together. And the hip fracture risk is horrifying. Once you get a hip fracture, it's like 1 in 3 will die in the next year. And part of it is you have a hip fracture and it pops some fat into your lungs and you can die of a pulmonary embolism. That is very common, and that is what we taught in med school. And then the wrist fracture is very common. You fall down the stairs, you put out your hand, you break your wrist. And so maybe we all need to learn some tumbling. And they've also shown that people that are more overweight as we get older live longer, I think, is padding, and also bone density. The heavier you are, people are wearing vests, right, to increase the weight. And so if you're heavier, you have natural weight on your bones, increasing your bone density. Back pain due to spinal fractures. Weakened grip strength is just showing weakened muscles, but also reduced bone density. How to prevent it: make sure that you're getting enough calcium and vitamin D each day. Don't go crazy. We had one patient who was like, if 1 is good, then 100 is better. And no, you can force calcium into your body if you take vitamin D with calcium, 100 pills. So no more than maybe 3 pills a day. So what I do is we have calcium with vitamin D in the middle of our kitchen table. And if you didn't eat calcium that meal, milk, yogurt, whatever, ice cream, then you have to take a calcium with vitamin D. And regular exercises. Remember, we're focused on weight-bearing cardio exercises such as actually stomping versus walking. And so we're all angry right now. Just like stomp as you walk. Jogging, strength training to pull on it and maintain bone density. Weight training, the resistance, squats, deadlifts, overhead presses. Not so much a fan personally of that, but totally we need to do that. And then HRT and bone density testing. It's sad, and we need to change this law that most people you're allowed by insurance to have your DEXA at 65. But as we talked about, this whole bone density thing happens at perimenopause, which is 47. So I think we should all get a a DEXA at 47 to see where we are, to know how much freaked out we need to get onto this situation, rather than 65 when you have osteoporosis and it's too late. And so, as you saw before, the indication is at risk for osteoporosis. Once you have osteoporosis, totally different medication. But before then, we can give you estrogen to prevent it. But once you get osteoporosis, then it's a different med. But I still think the estrogen's good even if you go there. This shows you the benefit of, this is the Women's Health Initiative estrogen only and the risk of osteoporosis. The relative risk is if you're on this medicine versus someone who's not, then there were 7 fewer hip fractures, 7 fewer vertebral fractures, 24 fewer arm wrist fractures, 53 fewer total fractures, and then percentage-wise, this is like 35% less risk of hip fracture. This is 36% lower risk of vertebral fracture. This is 42% decreased risk of lower arm wrist fractures and 29% overall fracture. So this is relative risk and this is absolute risk, which is fun and teaches some stats. DEXA scan is just an x-ray of your bone density. If your T-score is greater than -1, then you are, quote, normal, though it'd be better to be 0, which would be normal, but -1 will allow. -1 to -2.5 is osteopenia, -2.5 or more is osteoporosis. You should start scanning around peri/menopause and follow up every 2 to 5 years, depending how bad it was and how scary it could go. It's quick, it's non-invasive. There are places popping up to do it for like $100, $200. And you can also check your muscle versus fat portions if that's of interest to you at the time. So we talked about moderate impact, walking, jumping, dancing, strength training 2 to 3 times a week, aerobic exercises, 150 minutes of moderate or 75 of vigorous a week, and then balance. So group classes, video, Zumba, whatever, but you could also just stand on one leg for 60 seconds while brushing your teeth and stand on the other leg to check a balance is something you can do at home. Resources, websites, menopause.org is the North American Menopause Society, now rebranded as the Menopause Society. They're the ones that educate physicians and teach us. There's also the National Menopause Foundation, and that's more lay people education. Our website, obviously, Pandia Health, has a lot of info. Our YouTube has great talks that have been given by several physicians. My favorite books are How to Menopause by Tamsin Fatal. She is a journalist, but the book is pretty legit and good with sources. The New Menopause by Mary Claire Haver. She's a YouTube influencer, but absolutely Instagram and TikTok and all that. But absolutely a real OB-GYN who's been doing menopause for 20 plus years. She started most famously with the Galveston diet out of Texas, but now she's parlayed it into the new menopause, and then I think she has the new perimenopause, and she's gone on tour. She's just a huge sensation. My main thing is watch out for supplements. They are not FDA tested, not FDA approved, and I'd like to see them in a randomized clinical trial. They will tell you that their ingredients have been in a randomized clinical trial, and yeah, they're safe, but it doesn't necessarily do what they say they do. So just beware of supplements. And the menopause moment, Kelly Casperson's a urogynecologist and is really into testosterone, but also just we'll talk about vagina and sex and stuff like that. And so that's a good book, The Menopause Moment. And then Estrogen Matters for any doctor that's like, no, the estrogen causes cancer, just give them the book or tell them to do a quick summary on ChatGPT or something. The Menopause Brain, for those of us that are obsessed with dementia. Lisa Mosconi is the probably most renowned researcher of women's brains using functional MRI before, during perimenopause, postmenopause, comparing the parts of the brain. And hopefully she's getting enough data. She's collecting data on 20 million women across the world, but hopefully it is enough data to look at the different treatments. Like, is the patch better than the oral? Is it better at 0.05 or 0.1? Like right now, the standard of care is no tests and we treat your symptoms. But as a scientist, I think there's a number that we should treat to that's optimum for bone, optimum for brain, optimum for heart. And so there will be science in 10 to 20 years, but my joke is I will be demented with a heart attack if I wait until then. So I have to biohack until they have the data. And so it is a, what do you call it? Fact-free zone because we don't have the stats, we don't have the science. We have stuff trending towards it, but we may turn out to be totally different. So do no harm is the word. Ovary Active is a great podcast by two OB-GYNs. Love them, absolutely trust them. And then Dr. Louise Newsom is in the UK. They are 5, 10 years ahead of us on this whole menopause situation. But again, they're now having a lot of wellness people. There's like a whole lane in their version of Boots, which is CVS, Walgreens equivalent of a ton of different supplements. But I do think calcium with vitamin D, omega-3 if you have high cholesterol, or just eating a whole bunch of salmon, not a whole bunch, but like 2 or 3 servings a week. Or those are legit kinds of things that you may want to look into. And then there's 2 articles. Rachel Rubin, I love her too. Vaginal Dryness Kills, and she's a urogynecologist, I believe. And then Women Have Been Misled About Menopause by the New York Times. And then I don't know why I stuck the breast cancer one after that, but again, vaginal estrogen is fine after breast cancer. And Dr. Men is actually a Menopause Society certified practitioner who had breast cancer herself. And so she has a list of doctors that are comfortable dealing with breast cancers and treating and doing shared decision making and up to date on the latest greatest. Pandia Health, we're just here to give people basic peri/menopause care, limited to the FDA approved reasons. And if it's complex, then go see somebody in person. And I love that Dr. Men has put together this menopause after cancer clinician directory. And please follow us on socials at Pandia Health. Pan is every, Dia is day. I say that because people put Panda Health or your, so Pandia. Pandia is also the Greek goddess of healing, light, full moon. So we're all about women's empowerment. That's why we chose it. We believe in empowering women. And then we created Pandia Menopause, which covers menopause, perimenopause. And I'm developing my TikTok and sometimes Insta, but more TikTok with random talks on menopause every now and then. So that's it. And I want to thank you.
That was fantastic. Thank you. Thank you very much. Oh my goodness. There's so much great information there. I have to say there were plenty of times I wanted to pop in and interrupt, so I had to hold myself back.
Thank you. Thank you.
Yeah, no, that was really great. I'm kind of looking at my notes. I had lots of questions. I loved what you did in the beginning on the birth control. I didn't know. I didn't do a deep dive on your birth control work beforehand, right? I didn't know that you had analyzed so much and I didn't know there were that many options around birth
Yes.
control because I was on birth control for over 30 years.
Nice.
And again, I got put on it when I was 17 because I had horrific periods.
Right.
They were to the point I was afraid to sit down, right? It was that, and I would get
Uh-huh.
my period every 12 to 15 days. So it was, yeah,
Whoa.
and it was,
That
and
you would have had anemia and early
I did have
menopause.
anemia. Yeah, that's why they put me on the pill because I had anemia and I had really heavy periods that would last 7, and I would get it every 12 to 15. It was so bad. Yeah. So they put me on the pill and just here's the one, right? I mean, and that was years ago, right? That would have been back in, the
Yeah.
80s.
I was probably like 3 back then.
Yeah. And again, I didn't know there were many. I did learn after my kids. I had my kids in 2008 and 2010, so I went back on a pill. So then I went on a different kind, right? So clearly in that time they'd done some more research, but
Yes.
there was no analysis to your point, right? It was just here's the one you take. And
Yes.
then by the time I was 41, so in 2000, what would that have been? 2012, that's when my migraine started really, really bad. So I really at 41, looking back, I'm 55 now. Looking back, I can
Yeah.
now say I likely started in
Yes.
perimenopause at 41,
Yes.
but nobody told me that that's what was happening, right?
Yeah.
Because I was off the pill
Yeah.
from the kids, and then after I had the kids, I started coming back to normal. But then I didn't come back to normal right after the
Yeah.
kids. I went straight into this,
Yeah.
and I wasn't sure I wanted to be back on the pill.
Yeah.
And finally, I'm just like, I mean, the periods were weird again. So I'm like, I'll just do it for that. I didn't know the migraines were related. And looking at that now, I wish there was, I don't know if you had that analysis 10, 15 years ago, right? If that existed. But I mean, I think there's so much more information today to know I could have been on a different pill maybe to address
Yes.
these migraines. Like,
Yes.
would that have been a possibility? Because you're saying now don't go on HRT at that point. Go on a pill that's going to manage all those. Like you had a list of like what, 15 symptoms that
Mm-hmm.
could have been managed, which
Mm-hmm.
was holy, like 13 years I suffered before I got all this. I mean, along with many other, like I was the heart palpitation person. I was in the ER multiple times. I had chest pain. Like I had the whole host of things, right?
Yeah.
So, so knowing that that exists, like that, I'm keeping in my back pocket. One for my daughter,
Yes.
and right, and two for other women that just don't know that that there are that many options for birth control.
Yeah, no, so many women are like, I tried the pill. And it's like,
Right.
one, how long did you try it for? 3 days? Like, no, you got to give it at least 2 cycles. But also, just because you tried one, there are at least seven other progestins, two different doses of estrogen. And then there's also the new progesterone only pill, the old progesterone only pill. But I was like, as a geek who loves spreadsheet, how come nobody put this in a spreadsheet, multiplied it times its effect and the dosage and like blah, blah, and then rank them, And I was like, so
Right.
easy, me and my Excel spreadsheet.
I'd love that. I'd have been right there with you.
I know. I was just thinking, Angie, and you have a thinking process very similar because everything gets into a spreadsheet. I have a couple questions that I wanted to ask. First of all, about Pandea, do you take insurance?
So, for the doctor's visit, we don't take insurance, but we're quite economical. For the birth control, it's just 35 bucks once a year, unlimited follow-ups because I didn't want anybody stopping because they had breakthrough bleeding or whatever and couldn't afford the follow-up. For menopause, because you're older and it's a little more complicated, we have currently a monthly subscription. It starts at $69.99, or if you get a years at a time, then it's $420. So roughly $1 a day you get expert, menopause care, but only for these four indications, not other issues and stuff like that. But
Hmm.
it's a steal. There are people paying $1,000 to $4,000 to see a menopause expert.
Well, yeah, I mean, my deductible is more than 420 a year that I put towards, menopause
Yeah.
care. My other question is, with you having the obesity care and weight loss, do you prescribe the GLP-1s?
We don't, we were heavily leaned upon by our investors to just go into GLP-1s because, as you know, it's hot and it's a huge moneymaker. But we felt that we'd get pulled into just being GLP-1, distributors versus focusing on what we can do. So no, we do not prescribe GLP-1s. And then my tip would be that, try the estrogen if that's not sufficient and you need extra help, then actually metformin. It's not over the counter, but it's a generic, really cheap. It's like $5, $10 for a bottle for a month. And that is a medicine used to treat diabetes, just like GLP-1, but used in people with a family history of diabetes to prevent diabetes. So if you tell your doctor, I heard from Dr. Yen at Stanford that people take metformin who have a family history of diabetes, and who doesn't have somebody in their family with diabetes,
Yeah.
then and I would like that, then you can get this metformin, and you can take 2 pills twice a day if you need a lot, or 1 pill twice a day. They have an extended release, but for obesity purposes, weight loss, they've shown that the twice a day is better than the extended release. And I think part of it is I learned about generics, and some generics, like 24-hour release, just says you have to release this amount over 24 hours. And some people release it slowly over 24 hours, which would be good, or some people just spike it. And so the spike it one obviously is not doing a good thing. And so by having it twice a day, I guess it's better to have two spikes than to have just this one spike situation. So I would ask for not the extended release and 1 pill twice a day. And so those of us before GLP-1s came out who wanted to live to 100, 120 were like, everybody go on metformin because we're all going to become insulin resistant and die of diabetes and all the effects of that. And so whenever I think of it, I pop a metformin, but like that, not more than twice a day. But when I'm like,
Mhm.
I think I like my waist a little less, so let's throw down some metformin. Or I eat
Yeah.
some extra dessert, so maybe some metformin.
I have another question. You brought
Sure.
up the not going to sleep for 2 hours before you eat. I
Yes.
am on a GLP-1 and have been for 14 months now. It's been phenomenal, the
Yes.
results from it. But I eat teeny because I'm full quickly. And
Uh,
so I'm hungry again. And I
uh,
try to eat a little something before bed, but I always do a workout before bed. So can you
yeah.
offset that time frame if you're doing
Yeah.
some exercises before you
Yeah.
go to bed?
I think if you do some exercise before you go to bed, that'll offset it. But if you just eat and sleep, that is not a good thing. Or if you eat and
Mm.
watch TV, or if you eat and look at your computer, but if you're eating and work out, yes, that's probably fine. Your workout will metabolize, hopefully it up. But like I think an hour is probably minimum, 2 hours to be on the safe side.
Yeah, nice.
Good
So I
And
had a
then,
question. Oh,
oh,
no, go ahead, April.
okay.
Go ahead. Mhm.
Well, this is my last question, unless something pops into the brain. But um, this has been such an amazing journey for me in seeing how effective the right menopause care can do and advocating for myself. But I am 57 this year. I have a lot of friends who are going through struggles and trying to get them to seek out care.
Yeah.
They're still giving that, I'm afraid, oh, I don't know, even seeing how, my
Yeah.
whole life has changed and
Yeah.
how healthy I am and what I can do now. That, I mean, literally, I was with a walker 2 years ago, um,
Wow.
and and thought I was just deteriorating to,
The end.
the end. Yeah, exactly. Brain fog, and everything was just, you know, looked like assisted living was, the next birthday party going to be kind of thing.
Yeah.
And so to see where I've come in just 14 months of,
Amazing.
should be enough inspiration, but I can't, there's still such a resistance. And I just don't, I would love a perception from you or a narrative or something to
Yeah.
get people on board for caring for themselves and rejecting this culture of no, you know, do it, uh,
Naturally.
it's the rite of
Do
passage
it
of
natural.
aging. This is, and I can't tell you how many doctors said that to me. This is normal. Nothing you can do about it. This is just what happens.
Yeah.
So
Yeah. I mean, it is technically what's natural. And like I said, we were anything beyond 52 is gravy. We're supposed to be dead. And so if you don't want to be dead, then you have to do something to prevent that. And yes, naturally, I like to say like naturally I have horrible vision, but I got contacts and LASIX, Naturally, I have horrible allergies, but I take my allergy meds. Otherwise, I'd be running around going, wanting to die, which I was this morning until I took my Sudafed and my eye drops. So, and my nasal steroids last night. But so I think the key is sometimes people will do stuff for others that they won't do for themselves. And so you can say that you give them the statistic that this will decrease your risk of a hip fracture by, a huge percentage. This will decrease 60% of fractures could be avoided with hormone therapy, 50% of heart disease. So if you want to save your money, your family, the money of you being in the hospital, but literally the heartache of you being in the hospital, and you want to be like this is how I'm a pediatrician, so I use kids on their parents. And I was like, have the kid go up to the parent and go, Mommy, don't you want to see me graduate college? Don't you want to see your grandchildren? Because if you want to hold your grandchild or if you want to help with your grandchild, it'd be good if you don't have a bone fracture or heart disease or diabetes. And so if you
Yeah.
fear any of these diseases, which most people do, then consider HRT. And then the other part is saying, you don't get a gold medal for white knuckling it to see how long you
Yeah.
can go through it. Um, and
Like
I
you should
totally
put that
admit
down
this
when
is
you said that.
yeah, I totally admit this is unnatural. This is biohacking, so I can live as long as possible, as healthy as possible. And if you wanted to live naturally, then you wouldn't use antibiotics. You wouldn't use glasses. You wouldn't wear clothes. You wouldn't cook your food, so we are unnatural, but we're using science and technology to live our best lives. And this isn't like rich people stuff. This is like why have a heart attack? Why have a fracture? Why bleed like stink? Why have diabetes? Cancer is heartbreaking, colon cancer, all of this. But me, dementia, like don't leave dementia on your family that you could have avoided, right?
All right.
Yeah.
That's what I thought my brain fog was. And I
Yep, me
questioned
too.
everything. Like, am I, is this it?
Yeah.
I'm like, I can't remember things that and I was at in a direct executive level position and I'm in a meeting and can't remember my team's name.
Yes.
Like just like all of a sudden you just feel like you're, naked in front of the classroom in second grade.
Yes. Yes. Exactly. And
Yeah.
and it's humiliating. It's embar I don't know
Hmm.
anyone's ever have to look it up on the phone and I'm like blah blah. And the good news is I've always used my husband as a prompt. I was like, here's my husband Steve. And then see, hi, I'm Steve. And then they have to answer with their name. And like my husband is not doing that anymore. And I'm like, dude, this is really necessary. I need your help. I wish I had the special glasses that I could double click on everybody, like, who's that? Who's that? Who's that? Because I don't remember their name. It's so bad.
Yeah.
I would love it if, you're open to it, if you could do like a testimonial for HRT, because I think, April, you are the poster child that, you did a total 180 or at least 45-degree, diversion from that spiral down and you've actually, you've reaped the benefits. I think again, you can only be the example, and then you can say, this is what would be good for you. This would be good for your daughter. Like I want my parents around as long as possible. I would love them to be at my daughter's wedding. I want them to see my grandchildren, so they'll be great grandparents and I want them not to have a hip fracture and I want them not to have stroke and I definitely don't want them to have a heart attack. So and diabetes, nobody wants either.
Right.
Yeah. Yeah, no, absolutely. Absolutely. No, that was a great question. And I think what you said about like we're not living natural anyway, right? We have glasses, right? We have glasses for being able to see. We have
We
all
have
these
high
other
blood pressure
we
meds, we have cholesterol meds,
right. And
right?
nobody questions or challenges those and say you got to go on the lowest dose and you got to take it a shorter like none of those ever get questioned to that point. So why does this one get questioned at that level is just it really is shocking and surprising that it continues. So I guess it's more of these kinds of conversations, right? It's the more of these kinds of conversations, sharing these, putting these out to the public so that we
Yeah.
can get the word out and say, I was at this point, I was hobbling up the stairs like I was 90 years old. And now, I can run down the street with my dogs or whatever the story is, right? There's lots of them that we all have. And I think it's just getting those messages out there.
I
Um,
literally walked 2 miles this weekend with a weighted vest and my 70-pound dog who does not know how to walk pulling me. And I'm like, I can't, this is a dream come true. And my 24-year-old son is like, this is your dream come true. You can do this now. I'm like, once you have it taken away and you get it back, it's a
yeah.
dream.
Yeah.
So
That's amazing.
Yeah. Yeah. No,
I'm in
absolutely.
Texas, by the way, too. So when you brought up Dr. Mary Claire, we're like, that's home turf. She's my girl, and
Amazing.
I've been following her since the Galveston diet, and I actually lived in Wisconsin when that came out.
Oh
So
my gosh.
yeah, I do. I don't buy her supplements though, but I do follow her, listen to her.
Yes.
She's the reason I have a weighted vest. She's the reason I stomp around the kitchen when I'm cooking
Nice.
something and waiting for a temperature to heat up. I smash my feet around the island. The dogs have no idea what's going on, who I'm mad at, but it happens every time I'm in there. So
I love it. I
yeah,
think also
No.
bunny hop or skipping.
yeah,
Yeah.
yeah. Brushing the
Yeah.
teeth with one foot is
That
also
was a good one. Yep. I
normal.
like that one.
normal morning and night for me with that one too. So
Amazing. You have had a life turnaround.
absolutely. Yeah, definitely. Well, and I have to give kudos to Angie because I was, in that mindset. I don't want to do anything because I don't want cancer. I mean, I'll just age the way I'm supposed to age. And she started her journey probably a year before me and started feeding me the resources and videos of yours and videos of different people, and then I'm like, okay, enough is enough. I have to get some help. And I think the turning point was Angie invited me to Las Vegas for the hottest menopause party with Tamsin.
Oh,
Met
wow. You guys were
all of
there for
those.
that.
Yeah, we were in the studio with 66,000
Oh my
calling
God.
in and watching on Zoom. But there was so much. It was 10 hours, wasn't it,
Yeah,
Angie?
it was a full day. There were
And
about
there
100 of
was
us
such
in
an
studio.
education and understanding and hearing the stories. And I'm like, I'm done. And then there was a little break, and I ran into the founder of MIDI in the bathroom. And
Amazing.
I said, thank you for sharing. I said, I've been really hesitant to move forward with care. And she's like, oh, who's your insurance? And I tell her my insurance. She goes, we take that. Give us a call tomorrow. Like I was like, all
Nice.
right, I'm on it. Because I couldn't get menopause care here with the doctor. I went to the family practice. She goes, oh, no, I don't do that. You need an OBGYN. So I called multiple OBGYNs for menopause care. And they're like, no, we don't do that. We don't do that. And then one of the menopause care say, well, go see an endocrinologist because that's hormones. That's who you should be seeing. So I go to this endocrinologist, and he couldn't have been the most horrible human on the planet, and said, well, basically, you're going to die anyways, and I'm not touching female hormones. That's not hormones that anybody should be dealing with. That's just how things happen, lady. I mean, it was just horrible. And I'm like, okay, this can't be how patients are with menopause are being cared for, so I did end up working with MIDI, who, helped me with the journey. So
Amazing.
but
Yeah.
definitely value what you're sharing. And I really do appreciate, because I do have a daughter too. And she's 22. And so that information, even just, birth control and things like that, having a resource like you would be, an advantage for her too. So that would be great.
So I have one last question, because I'm super grateful, and I know we're a couple minutes over time. So my daughter, who's 18 and she has challenging periods, is there something from your site that I could send her to look at? Because I talked with her. I said, if you want to do birth control, it's totally up to you. I did it. I wouldn't recommend the way I did it, but I didn't know this option. So is there something you'd recommend I share with her to take a look at?
Yeah, I would send her, I'm dropping in the chat right now,
Okay,
the link
perfect.
to periods optional,
Perfect.
and it goes over the science and safety of not bleeding every month, that it's actually natural to have fewer periods than we have. And then tell her, that we have an algorithm for picking the best birth control pill. 93% of our patients are happy with the first pill. And the 7% that aren't, we know how to manage to find the next one.
Right. And I think part of it was her story, she's hesitant because of my story, right? My story wasn't a good one. So if I can give her, information, and she's a data girl, she likes to look at it too. So, so I will absolutely send that, and, maybe we'll get her set up with you guys. That would be fantastic.
That would be great.
Yeah, that's what Annabelle needs to mine, because when she turned 18, I'm like, oh, you have to make an appointment. You have to get an exam. And she started calling, and they said, oh, no, not until you're 21, not until you're 21. So they wouldn't even see her until this year. So
that's so crazy.
So backwards. Or so, again, I feel like our medical system has been established by men, for men, focused on men. And we're not only fighting, our own journey in health, but we're fighting a culture change of a patriarchy that has been established for what the man's need is,
Yes.
So it's just a double whammy. So we got to help our daughters get
Yep.
ahead of this curve.
Yes.
100%.
Yes. No, you're reminding me. I have a medical school colleague who now runs a health system in Texas, and I'm hoping his health system is better because he's from UCSF, so I would hope that he did better, but I don't know. I'd be curious. I'll have to Google it and get back to you what that one is. Menopause brain.
We get it, right? Well, again, thank you for staying over. Thank you for all of this incredible information. Honestly, this was so amazing. I can't wait to, I will send you the full thing and then you can
Thank
cut it, slice
you.
it, and
And
dice
clip
it
it.
however you want. I'm going to do
Thank
the same
you.
thing. This was really, really great content. I appreciate you. Thank you.
Thank you, Angie. Thank you, April.
Absolutely. All
Thank
right.
you.
All right. Take care.
Good
We'll
night.
talk soon.